It's a pleasure. Good morning. Thank you, Sarah and colleagues, for the invitation. I was asked to give a higher level version of von Willebrands, and so if you ask, that's what I'll do. For those new to this disease or new to the group or whatever, the first half will be sort of basics, and then the rest will be what ifs, why nots, and what's going on, and what can we do to improve the situation. So basically, I throw these slides out to the group. Hopefully, I'll raise more questions to you than you will to me, and get you to think and cogitate and agitate towards what needs to be done in this field. Von Willebrands, basically in a slide or two, is right here. It's a bleeding disorder. Nosebleeds, epistaxis is the $400 word. Bruising or ecchymosis is the $400 word. And then a woman not in labor, but presumably in cramps and having her period that's longer than normal and heavy, and can lead to most cases anemia and sometimes severe anemia, and has obviously major quality of life issues. So from an engineering standpoint, I want you to think you're all now little engineers. You can think of, I don't know, I guess this is, I'm showing my age, Lincoln Logs, or now new day Lego blocks. Von Willebrands is basically, if you will, an engineering wonder. It's little pieces that get thrown together to form a big piece that is functional. And the little pieces really don't function. And if there's not enough big pieces that are put together, that's when you run into trouble, and that's what the disease is. And depending on where these Legos or Lincoln Logs are assembled will determine how big this structure is and how well it will work and what kind of disease you have. And from a more technical biochemical perspective, this is a picture, if you can see my arrow, this is a von Willebrand's monomer. It's one of those Legos or Lincoln Logs, and it's color coded into regions because, you know, scientists like to do that stuff. And it shows basically up here that basically the red ends dimerize. They form like stacks of coins back to back. And then once you get this dimer, these blue ends link up, these dimers, and then this just continues on and on and on to form a giant protein that has lots of functions. And the functions are listed here. Factor VIII binds here, so it carries factor VIII. Without von Willebrand's, you have no factor VIII because this shrivels up and goes away. These GP is glycoprotein. These are receptors on platelets. And basically here and here are major areas where this protein sticks to platelets. And then here is collagen. This is the glue that basically is in all the blood vessels, that when it's exposed, basically this region here sticks to that. So this protein is designed to stick to stuff. It sticks to factor VIII, it sticks to platelets, and it sticks to the blood vessels. Now, I told you that these dimers multimerize and basically form this giant structure. Well, sometimes in medicine, we have problems where there's too little of something and then there's too much. And when this structure gets too big, it causes blood clots. And that's what this scissors and atoms TS refers to. This is a totally different disease, very, very rare, where this mechanism, this protein here, which is a scissors that cuts the von Willebrands, if you don't have this protein, you either are born without it or develop an antibody to it, you will develop a very serious lethal clotting disorder, all based on the same protein that you're all here to hear about, that is here to prevent bleeding. So here's nature in one little slide. Too little, you bleed. Too much, you clot. And that's the world that we live in. The multimers, you probably have heard of this. This is another scientific thing to look at and not shrug off because it's important. If we look at it, it's a gel. It's like a slab of a gel, like Jell-O. And basically, scientists have used it for years to separate things by size. Bottom down here is the smallest, top up here is the biggest. And you run a gel and it just says sieve. And basically the smallest stuff is way down here. And then as it gets bigger and bigger, it runs this way. So basically lane 2 is what would happen if we took plasma and labeled it from a normal individual. We see these monomers down here, and then all of a sudden the dimers and then multimers of that go bigger and bigger, bigger. You can't see it anymore because it's a big smear. And again, in nature, lane 1 is someone who inherited mutations for severe von Willebrands, meaning type 3, where they don't make any. You run this gel and there might be some monomer here, probably not, and you get nothing. Then type 2 patients are here in lane 3 and 4. And look, you see the multimers go up and then stop there. And in here they go up, and stop here. And then there's another rare form of von Willebrand's disease called platelet von Willebrand, where there's nothing wrong with the von Willebrands. It's the platelet has issues. It cannot stick to the von Willebrand, and you get to see this high molecular weight form. This is also the form seen in this disease, rare disease called TTP, which none of you want. This is a devastating disease, and you get more of these high molecular weight von Willebrand multimers that cause clots in all your organs, and it's again, except until recently, was a lethal disease. This is to show you the structure by electron microscopy of one of these multimers that's shown here. These arrows are basically these dimers, and they're just all linked up, and you have to use a special microscope to see this, but it just shows you how actually big and spread out this protein is, and that's the point of this slide, to show you that all these little pieces are all hooked together to form this long chain, and each part of it has a function to bind to different things. And this is basically summed up in this slide. Here's the purple, is the von Willebrand's protein. Here's factor VIII is stuck to it and carried by it. This is the mothership that carries the baby factor VIII. And basically then you see here, the von Willebrands can stick to collagen in the vessel, can stick to platelets, these yellow things, and basically forms an anchor for where eventual clots are formed. And you might say, well, okay, well then you should have some pretty severe bleeding problems if you don't have this stuff. And some patients do, but in general, most patients don't, because there are other systems at play, fibrinogen, all these other liquid factors that are in your blood that basically come out of solution and sort of take over this whole situation. So von Willebrand's, like any other disease, has multiple sides. If you don't have it, it's a devastating disease. If you have too much of it, it's devastating. And most patients are in between, mostly on the side of what we'll term type 1 patients, where they don't make enough of it, but there's just enough there that it works. And then the rest of all the other systems that I can't show you right now come in and take over. So the bleeding disorder of von Willebrand stretches from devastating to not so bad. And it really depends on where the mutations are in this that lead to defects in this protein, as we went through earlier. And that's shown on this slide. This is a paper that basically looked at mutations in, these are called exons. These are the sequences of DNA. You can see them numbered here, 2 to 52. This is a big protein, 52 exons. That's huge. And basically, the more sequence you have, in effect, there's more room for error. And depending on where your error is, as we'll show you, there's hot spots. There's a hot spot here in type 1 disease. Look, type 1. Basically, you don't really make enough. You make it, but you don't make enough. But look, different patients have mutations scattered all throughout. The hot spot seems to be in this exon 28. Type 3, where you don't make any at all, also scattered all throughout the gene. And then you look at particular types, type 2A and B, this is exon 28, type 2M. So many of your doctors may have done genetic testing to confirm the diagnosis. That's the gold standard. And they might, because of this work, just sent off to a lab and said, just go ahead and just do the sequencing in exon 28, and that's all I need to know. And for patients who have very low factor VIII levels, that's type 2M, there's a stretch in here, these exons where factor VIII binds, and you tell the lab, just sequence this and we'll confirm or deny the diagnosis. The types 1 and 3, the gene is so big, it's difficult to sequence and also more expensive. So in some cases, it's important to do. In other cases, we just diagnose you clinically and from lab work that looks at how active or how much factor is or what your multimers look like, as I showed you in the other slide. This is an important slide because von Willebrands is a difficult disease to diagnose. I don't know why my colleagues don't say this, but it is. If you look at this, this slide, one compared normal individuals with patients who are bona fide von Willebrands. And if you look at, from a clinical perspective, nose bleeding, heavy menses, bruising, bleeding from minor cuts, bleeding from dental extractions or just gum bleeding, bleeding after any kind of surgery, blood in your joints, or gastrointestinal bleeding, you don't have time to look at these numbers, but the overlap between von Willebrands and normal is pretty big. It's pretty big. What I went through here, this scoring system, is what's called the BAT score. And basically, any doctor who is in this field who thinks you have von Willebrands should, in their mind, and have asked you all these questions. And you add up the results from this, and you go, this patient either has disease, maybe has disease, or doesn't have disease, based on the answers that you give them, based on these simple questions. But even based on that, look at this: gingival bleeding, dental extraction bleeding, normals 7 to 28%. To all types of von Willebrands, 19 to 28%. There's overlap there. Postoperative bleeding, normals 1 to 28%. All types of von Willebrands, 19 to 28%. So you can ask these questions to get a sense from a patient whether they may have the diagnosis or not, but you're really not sure, and that's why you have to do testing, which is the multimers and other assays, and finally, the coup de grace, the gold standard, is genetic testing. This is a slide I give my fellows every summer, the new fellows that come in, because they're inundated with, they're basically at our place, they're basically given one month of tutorial to learn hematology and oncology, which is actually unique. I don't know any other group that does this. And we based them, basically, they got 4 years of medical school. They went to do residency for 3 years, and now they want to be subspecialists in hematology oncology. And all the faculty go and throw basically in a month everything at them. So I don't expect them to remember anything except maybe something off of this slide. And so basically, von Willebrands, it's a large gene, huge gene, which equals lots of mutations, which means there should be a lot of patients with this disease. The von Willebrands protein sticks together like Legos, I already told you about, has many functions. For blood clotting, think of Velcro. And each part of the huge protein has a different function. It sticks to different things. Each mutation can cause a different part of this protein not to work. So the type of mutation equals the severity of the bleeding. There are several types of von Willebrands. Type 1 is the most common. That's where you just don't make enough, but you still make it. Type 2 is basically, it's made, but it doesn't work. And 3 is, it's not made. So, so which would you think would be the most severe disease? Well, type 3, type 2, and there are some patients with type 1 who have a type that is made, but it's destroyed rapidly. It's called type 1 Vincenza, because Vincenza, Italy is where the patient came from. And so in effect, this type 1 Vincenza acts like a type 2 or 3. So depending on the type, depends on what treatment you get. All patients can receive von Willebrand's protein. Severe types all need von Willebrand's factor protein. Other types, some type 2s, type 1s mostly, can get DDAVP, desmopressin, TXA, tranexamic acid, or ECA, Amicar. And it's my view, this is Dr. Walsh's view, in von Willebrand's is number one, this disease gets no respect. I hate to say it, but it's true. There are probably more patients than all the hemophilia patients out there, but because largely most patients are mild and don't bleed all the time, that means they don't need a drug all the time. It doesn't get the respect it needs. Testing and diagnosis is, as I'm trying to tell you, it's not straightforward. It is not hemophilia. Factor whatever is low. No, it's kind of low, but functionally it might be low or not low, and their bleeding score, their BAT score is it's either high or low, not so sure. And finally, really, without von Vedi, which came out 5-8 years ago, nothing new has happened in this disease for over 40 years. So what's the deal here? Dr. Walsh asks the drug companies. So I'll ask the questions to you before we start. There's no audience participation here, so I'm just going to answer these. But when was VWD discovered or first described? 20, 50, or 100 years ago? And the answer is over about 100 years ago. Dr. von Willebrand and a little met a young woman, a young girl, 14-year-old, who had incredibly heavy menstrual bleeding. She came from an island off the coast of Sweden. And unfortunately, that young girl died of bleeding. He just described it, and it's taken 100 years to get to where we are today. How many different drugs are available to treat von Willebrand's? 1, 3, or at least 8? And the answer is at least 8, but as you'll see, nothing really new except for this newer drug, Bombendi, has really come for patients. Is DDAVP desmopressin used for treating bedwetting, or wet bedding? Either way. And the answer is yes. And it's important for you to know because of the next question, stymate or DDAVP. What happened was an investigator in Italy discovered that this, which had been around, which is a hormone that basically was used for your kidneys to retain fluid, to retain water, so children at night would not wet the bed, at a basically 100 times more concentrated dose, found that this drug would elicit von Willebrands out of the liver. And so right away, there's a drug that you could use, either inject, or they found out you can sniff it or snort it, hence stymate. And it gets into the bloodstream and away it goes to the liver and elaborates it, and there you go. Is DDAVP in the form of nasal stymate available in the US today? No. The company that made it basically screwed up. They over-concentrated it and they pulled it off the market. It probably won't be available at least for another year and a half. And how many types of VWD are known? 3, 5, or 9? At least 9. All right, I'm running out of time here, so I have to go fast. Are all types of von Willebrand treated the same? They can be. All of them can get factor, but type 1s and some type 2s can get stymate. And are Lystata and Amicar new drugs for von Willebrands? Absolutely no. These are ancient drugs. Huge pills, hard to swallow, but they're Amicar, I know comes in as elixir. You may know if or not whether Lystata does or well, is a liquid or not. Do von Willebrand levels typically increase during pregnancy? Yes or no? For most patients, yes. For the severe patients, the severe 2s or von Willebrands, no. No, they do not. Do von Willebrand levels increase as you age? And the answer to that is complicated, but to make you feel good, I'll say yes, it does. But does that necessarily mean you won't bleed? Or in all patients, the answer is no. So it's really up to you and where your mutation is. Current treatments we went through: Lystata, Amicar, DDAVP, stymate, and all the drugs here that are shown. Bombendi is the latest drug that's made from cell lines. It's not made from plasma. Vaginal bleeding, hormonal therapy, at least in my experience, works the best. And even better is Mirena rings, which are implanted. These are IUDs that are coated with a hormone that work locally, so you don't get systemic effects from the oral pills, and make a huge difference in women with von Willebrands who do not want to have children or have difficulty with the other drugs. So that's part A of the talk. As you know, this week, Branson and Virgin Galactic blasted off into space, hoping that all of us will, instead of going to the beach or wherever, the mountains, or go visit wherever, you'll go visit space and pay, what was it, $250,000 or $200,000? Well, we'll see. Maybe if they have super saver rates and coupons or something. But for most of us, I don't know if this is achievable, but hey, good luck. And I think Bezos is taking off in a week or so. They're debating who's going into space. So the point here is, let's get some new ideas in this field. Or basically, why does hemophilia get all the good toys, all the new ones? Because there are more patients that need more product all the time, and so there's a profit incentive, pretty obviously. But hey, come on. So if they have driverless cars, commercial flights in space, why can't we do better for VW? Well, here's an idea. And this is for the severe patients. This is a drug called a factor VIII Memetic. This is how factor VIII work. This purple blotches here. Basically, factor VIII helps factor IX and 10 get together. They kiss and they activate clotting. So what a group in Japan did many years ago is made an antibody where one arm bound to 9 and one arm bound to 10 and mimics what factor VIII does. The beauty of this drug is that it can be given subcutaneously, and we have patients who use it every 2 weeks or every month. So injecting the factor VIII 2 or 3 times a week to a little needle stick like you had diabetes once a month, you can imagine this drug has taken off in our field. And from what I understand, is the leading drug for prophylaxis in the factor VIII world. So, well, how could that be helpful to von Willebrands? Well, here's 2 papers. I proposed this at a meeting 4 or 5 years ago, and I don't know if they heard me or we all have the same ideas, but basically, here's a case of using this drug, emicizumab or Hemolymer, I just showed you, this antibody that works like factor VIII, in a pediatric case with type 3 von Willebrands. This baby basically had an antibody to von Willebrands, and so would clear the von Willebrands protein right away. And they gave the baby this drug, emicizumab, and effectively the baby didn't stop bleeding. No more bleeding. Here's another paper that just came out. 2 patients, no antibodies. They were basically severe patients, I believe type 2 and type 3. And they were treated with the emicizumab, and it significantly reduced bleeding. These authors were careful enough to say they had only followed patients for 6 months and really, in effect, hadn't had any bleeding, but they didn't say no bleeding or whatever. They said significantly reduced. And so here's a drug for hemophilia that could be used for severe patients with von Willebrands. And hopefully somebody will do a study and the drug will be approved for that, or we'll just use it off-label as Dr. Walsh does for a couple of his patients, and it works great. Here's another idea. This is just to get you thinking. Here's factor VIII in blue. This, I'm sure you don't remember, but all these domains of von Willebrands, this is the D section down here in red. We learned over the years that basically von Willebrands controls factor VIII. It binds to it, it shepherds it, and if you don't have it, the factor VIII goes away, but also controls how long factor VIII stays in the blood system. So this factor VIII has been modified by hooking all sorts of things to it, but also the most important thing, I think, is this section of von Willebrands protein. And so what I'm trying to convey here is, well, if this is how we regulate factor VIII, how do we re-regulate von Willebrands? What can we do to modify that to where it's not destroyed as easily, what little amount is there? We either boost what's there, like a stymate, but either genetically or a protein that acts like it, or it doesn't break down as fast, or both. It's made, stays around, it just won't break down. And that's just an idea to throw out. Here's something else in the field of just bleeding disorders is, this is a cascade mechanism of how blood clots. And there are regulators to how your system forms a clot. Obviously, you don't want bleeding, but you don't want clotting as well. You don't want the system in overdrive so that you're forming clots all the time. So what investigators have done is basically attack the control points, the regulators here, these two proteins, of diminishing them, reducing them or their effect, so you form a clot. And this one group used this very sophisticated, what's called RNAi. It's a system that goes in and finds your RNA for a particular gene and cuts it, so it's dead. And that's being tested and has shown to have effectiveness in hemophilia. If we found what regulated von Willebrands, maybe we could do the same for that. Then there's gene therapy. This is the AAV virus, adeno-associated virus. And basically, why hasn't anybody done gene therapy for von Willebrands? So what I told you is that this is a huge gene and really doesn't fit into any of these viruses. The viruses just act as a suitcase to carry DNA or some kind of genetic material around. There's really no really good way to do that. So at least not the whole gene. But Dr. Walsh's lab has been working on this for many years unsuccessfully. And we've tried different ways to do this. It's not insurmountable. It's just, I haven't found the right postdoc with the right amount of luck to get this to work, but I know it will. Then there's the Crispr Revolution, just so at parties and whatever you could say you know about CRISPR. Basically, the woman who won the two women who won Nobel Prizes for this basically had no idea what they stumbled into, other than they found a protein in bacteria that would cut up the DNA for what are called bacteriophages. Phages invade bacteria and basically kill the bacteria. Well, the bacteria makes this protein, CRISPR, that would go and chew up this bacteriophage DNA. And basically, it didn't take scientists more than 5 nanoseconds to figure out what that meant. When you cut DNA, one of the first things you learn in the lab is if you cut a gene and let it reanneal or reform itself, there's a 2/3 chance that it will form a mistake. That's the triplet code. And basically where there's a mistake means a mutation, and where there's a mutation means that protein that's eventually made from this mutated gene that you did won't work. So CRISPR is a great way to cut DNA and let it reanneal and form a 66% chance it will be screwed up and it won't work. So if you want to get rid of something, this is the greatest thing for it. The more sophisticated approach, and one that's harder to do, is to cut DNA and then splice in exactly what you want into that, between those cut ends. It can be done, it has been proven to be done, but it's very inefficient. And one of the problems with CRISPR is it's cutting DNA, and you have to make sure it cuts what you want and not other genes all scattered through your genome. That would not be good. So that's where that is. And it's moved from this very primitive form into bacterial cells, fish, and human cells. Now it's being used in patients, and actually looks like it's going to be good. Finally, there's cell therapy for VW. Why not? I don't know if you're familiar, but there's an ongoing study by a company that has basically found little spherules loaded with cells that manufacture factor VIII, and they implant these in what's called your omentum. This is why all of us have a middle-age spread. The omentum is a giant fat pad in your belly, and they implant these spherules, zillions of them, and basically let these cells make and elaborate, in this case, factor VIII. And they can measure some sort of factor VIII. Unfortunately, I know about this because the company doing this had the FDA put a hold on their study because one of the patients developed an antibody or inhibitor to the factor VIII. And so hence the risk with all clinical trials. But the whole idea about putting cells into patients has been in memorial and has just never worked, because the cells you implant have to be encased in some kind of system, and that system gets overwhelmed by the body. It gets fibrosed, it gets treated as a foreign object, and those cells die off, and it's never worked. And it looks like the system this company has might actually work. We'll see. Basically, to end this, I'm going to talk about prophylaxis in hemophilia, von Willebrand's disease. I know we're running out of time here. Basically, this one best study was by Holm, and basically they showed in this column all von Willebrand's types patients with all their different kinds of bleeding, and basically you get on a regular IV dose of a von Willebrand's product, and whoop, your bleeding rate is here. Now it's cut well over half. For type 3 patients, it's cut even further. And so for those patients out there that have severe von Willebrand's, I beg you, if you're not doing this already, to consider, if you're not doing it already, some form of prophylaxis where you're receiving the protein all the time. And basically, to end this, the community has not forgotten about von Willebrand's. These organizations, ASH, American Society of Hematology, ISTH, NHF, WFH, all came up with a panel of experts to come up with new guidelines for von Willebrand's. And basically, they've changed how the diagnosis is made to some degree. Basically, small changes here or there, but in general, for patients, nothing really major, because nothing major has really been developed for this in this field. So yes, you should do prophylaxis. These are what some of the new recommendations. Should you do it? Absolutely. Should TXA, tranexamic acid, and hormonal therapy be used for women with heavy menstruation? Yes. Should antiplatelet agents be used in von Willebrand's in cardiovascular disease? The answer is a qualified yes, especially if you have mild von Willebrand's, or if you have severe disease and are on prophylaxis. These are, in my take on what they found. So for information on BWD, go to your HTC staff. Websites abound. Certainly MIHA, Foundation for Women and Girls with Blood Disorders. That meeting is just happened or happening. And for those more sophisticated, Medline or Up to Date, this is where doctors go. To be recertified, you have to go and take a test every 10 years. They allow you, the doctors, to use this as a source while you're taking the test. It's called Up to Date. And with that, I hope I haven't gone over too much, and I thank you very much. I hope I can answer any questions you may have.
Excellent. Thank you so much, Dr. Walsh. That was wonderful. I have to say, especially appreciated your transition with the space flight or space race that's happening as a way to talk about innovative therapies. Lots of comments in the chat too about people mentioning their experience so far with Prophy. It sounds like there's at least a few folks who have transitioned or their children have transitioned to Prophy, and that's been really life-changing for them. So thank you for speaking to that. There is a question here, excuse me, are there any advancements on the testing for VWD? My children were tested multiple times. They tested positive and were treated. 2 tested positive, excuse me, and were treated. 1 is symptomatic, but she still needs, but she still tests negative.
So as I'm trying to tell the audience, this is a difficult diagnosis to make. And ultimately, what I'm telling you is the gold standard is to have the gene sequenced. That really, that is really it. There are not many places that do that, but there are commercially. Versity in Milwaukee will do this. And there may be other institutions that do it as well. But the fact, von Willebrand's levels are extremely problematic. If you draw the blood, so many times patients come to our center with von Willebrands, and I would say half the time I have to tell them, no, you don't have it. And that's because of what's called the milk box issue. If you go to a local doctor or place where the blood is drawn and then sits for a period of time before it's analyzed, the von Willebrands and factor VIII are destroyed. There are particular also disease states that I don't want to get into where what are called myeloproliferative disorders, because the platelet, platelet count is very high. The von Willebrands is destroyed. And there's a whole field called acquired von Willebrands. But it's not unusual to see patients come with modest or significant reductions in their von Willebrands. And as I told you, the BAT score kind of gives you a clue whether or not this is real. But at our shop, we just had clinic yesterday. Blood is drawn, it's prepared, and immediately it's frozen and then it waits for analysis. And I can't tell you how many times patients who came to us that had von Willebrands, we say, I'm sorry, in our lab, you're normal. And their bleeding score, they go, well, I do have nosebleeds. And I go, yes, but, and then I go through essentially what I've told you. And the only way to actually make a diagnosis final is to have sequencing of the gene itself. And that is not easy. That is, the system is not set up where this can be done rapidly. It's just not. It should, it's something that those in this field who specialize in this field should address, but it really, in my view, has not been really attended to well. I hope that answers the question.
Thank you. Another question that just came in. This person says, I'm an infrequent infuser, generally getting infusions via home care or outpatient when needed. But between the pandemic and Stymate being off market, starting to wonder if I should be prepared for home infusions. Do you think it's necessary for infrequent, mild, moderate patients, type 1, to be educated? My HTC is hesitant.
So if you were at our center, you'd learn how to infuse yourself. All our patients, we do whatever we can so they learn to infuse themselves. If you cannot, and we have some patients that just physically cannot or are not capable of infusing themselves, we find a family member or a friend or whatever, a good friend or very good friend, who will infuse you or infuse those particular patients. But we like to make our patients independent. We don't like them to have to go to hospitals or clinics or whatever. We just do not do that. I think it's because our clinic was set up, we never really had space for that. And so we do everything we can to make sure that they can take care of themselves at home. And when we hear from them, then we know that there's something wrong. And I would urge the listener to do that as well. The other thing is, depending on I am not your doctor, but I'm just telling you how we do things. We use tranexamic acid like candy. It's like bowls of M&Ms in our clinic. We find it works really well in mild to moderate patients. It basically takes a whole layer of bleeding away that just by taking that medicine as needed. And actually, I have some patients who've been on it daily for a few years. And they, in effect, have almost stopped bleeding. So there's different ways to do things. But again, this relates to the drugs that are available. I think the fact that Stymate is not available points to the fact, well, we definitely need new entities, new drugs that are easy and more convenient to give to patients that have this disease.
Great. Thank you, Dr. Walsh. There's a follow-up question. She says, that's really interesting as a follow-up. Where can we go for infusion training?
At our place, our nurses will train you. Absolutely. That's what they do. And they're very good at it, I must admit. So go somewhere where somebody can show you how to do it.
Sarah?
Yeah, Heather, please.
So I just learned how, at 57, learned how to infuse. So I had my home healthcare company come out and they taught me. The hospital sent them out to me to teach me, so.
Right. So there are financial considerations. There are all sorts of considerations, and I'm not going to get into that. But you can, as long as you get the drug, I mean, I don't really care, how you do it, but to be self-sufficient, if you can, means you don't have to call anybody, you don't have to do anything. The drug is there, it's in the refrigerator. If you need it, you're the one who knows how to do it. And you're not waiting in emergency rooms and all that sort of stuff, which is just unnecessary. It's a real grind.
Thank you, and congratulations, Heather. I know that was a big milestone for you, so that's awesome to hear. There is another question. Somebody asks, what do I do if I'm not located near an HTC?
Good question. Well, I mean, I'm sure you must have a local healthcare facility, local docs, clinics. I'm assuming this is someone who needs intravenous infusion of Willebrands. Is that correct?
They did not mention that specifically in their question, although if you want to unmute your line or share more, you're welcome to in the chat, and I'll keep an eye out for that. Let's see. No, it's mild, they said.
So your options really are, again, I'm not your physician, but your options are tranexamic acid. You take it as you need it. You learn how to infuse, and you can even do it online. Because of the pandemic, we had clinics virtually, nothing affected our clinic. We had virtual clinics from the day New York was shut down, and we still do it. I still do clinics in the morning on Fridays. And we had our nurses on FaceTime or Zoom or whatever. They would guide patients through how to give injections or infusions or whatever it was. So modern technology is, I think the pandemic, if it showed anything at all, and why we're having this Zoom conference, is that there are ways to get things done, and where you really once you learn how to do something, you know, you're now independent and can do as needed. You know, I don't know if the HTC in your locale does FaceTime or Zoom or whatever. I would hope so. That's another way to stay in touch and learn things or get help. But that would be my recommendation.
Great. And as a follow-up to that, I've had a few people mention in the chat just how much they've appreciated your presentation and your candidness and willingness to share with us. And so it sounds like maybe you have a few people who would like to be new patients. So the questions are, would you do telemedicine with patients in upstate New York? And would you be able to treat a patient in Massachusetts?
So I am licensed in the great state of New York, and I suppose I could do a virtual clinic, sure. Never been asked that before, so I don't know. You know, when it comes to rules and regulations at my hospital, never sure, but quite frankly, you know, if somebody was to FaceTime me, fine. Massachusetts, I am not licensed. So basically I would be acting as a consultant, I suppose. I could not prescribe anything. That's one thing the pandemic did. I was given, because we have several patients in New Jersey, I was given a temporary license. Most of us at Sinai were given temporary licenses for in New Jersey. I think that's expired. But you have to realize there are limitations. So a FaceTime or a virtual clinic are always possible. I don't see why. I don't see that as an issue.
Great, thank you for answering that. Just goes to show people have really appreciated that the presentation and sounds like gotten so much out of it. I had one more question that had come in separately. Somebody asked if you would be willing to share your thoughts on genotype versus phenotype.
Yeah, well, that essentially is, that question is a very, very good one. That's essentially what I was trying to show throughout this entire talk is, I don't know if you can see this. This is the protein, and these are the functions. And so the protein gives you a phenotype. Phenotype is what I can see, what you and I can see. Genotype is this, where the mutations are, okay? And so the point I was trying to make here, maybe I didn't make it, type 1 and type 3, look at where the mutations are. They're pretty similar, right? Yet this is, in general, a mild form of disease, and this is severe. And that's because it really comes down to luck, where the actual one base out of place in the wrong, this whole sequence, one base difference from here to here converts a mild disease into a severe disease, where you make not so much, you don't make anything at all. Here you see these type 2 patients are effectively all in this one region here. That's where all the mutations are. Why this was, why the great being or God or whatever did this, what in nature proposed to do this, we do not know. But that is it. This is genotype. And depending on where these mutations are, changes how this works. And then that gives you the bleeding phenotype. And that is genotype, phenotype.
Great, thank you very much for that. Excellent. Well, it looks like we have answered all of the questions from the chat. But once again, Dr. Walsh, thank you so much for this presentation. I think just looking at the comments that have been shared, it seems like people have really appreciated your willingness to share more of an advanced level presentation, as well as your candidness and thoughts on treatments and kind of where we are and where we're going. So we appreciate that very much. And appreciate your time. I'm sure that you'll be hearing from some folks later on. It sounds like, as I mentioned, there are a few people who are particularly interested in following up. So thank you for that. We'll take just a quick moment as we transition into the next phase. If anyone wants to grab a drink or grab something to eat, use the bathroom break, why don't we do just a couple minutes, and then we'll go ahead, we'll give away a few prizes, and we'll get started with the next portion of our presentation. So again, thank you so much, Dr. Walsh.
Thanks for having me. It was a pleasure. Have a good weekend, everyone.
Thank you. You too.
Be safe. COVID's not over yet. All right. Bye.
A very good reminder. Thank you.
Bye.